does it. So we have got lot of stuff to cover. We have got 4 candidates. Each candidate will stay with me for about 40-45 minutes. We will take 2 breaks after 1 hour, and then after the second hour. It's going to be a 3-hour session. So let's start. Candidate 2, I can see candidate 1 also. Let me go to candidate 1 so we can follow the order.
Okay, no problem.
Candidate 1, can you hear me?
Yes, sir.
Okay, so let's start. Uh, just a recap that this is part of the A to Z course, which we are broadcasting on weekends. And then we realized that this course we did in 2020. Overall, these are about 40 sessions. And we covered whole of radiology in this. This was on the peak of the COVID. So we decided to rebroadcast it. There were a few sessions which apparently the recordings were not optimal. So I decided to do them live. And today is one of those sessions. The A to Z course, MSK, is designed on a textbook of radiology. And we went through chapters. The idea of A to Z course was to go through whole of the curriculum in a textbook fashion, but in a 2B format, case after case after case. So today, what is my mandate? When I designed this, I designed it on a textbook of radiology, which is David Sutton. And these are 11 chapters in MSK. And today's session, I am going to cover lymphoreticular and hematopoetic system, metabolic and endocrine, and a bit of soft tissue. This is what my mandate today is. These are the topics to be covered, which I will cover today. You can take a screenshot of it. I'll show it to you again when we go to a particular chapter. So there are 27 different things which we are going to cover. And of course, there are going to be multiple cases of each from the 2B perspective. It's going to be plain films, plain films, plain films. A bit of MR will be there, rapid fire. And the aim is to show you a lot of plain films. Please remember, these things you don't see in your day-to-day practice these days. Your generation, you don't see them. And particularly people here in UK, you won't see, things like hyperpara and things like that. But in the exam, and why don't you see them now is that they are diagnosed much before the manifestations are, on X-ray. So in the exam, they show it, and in the differential also, these concepts are very, very critical. So I will advise all of you to be very attentive today. There is too much to cover, but it will be, I think, a high yield session. So first of all, lymphoreticular and hematopoetic disorders. And these are the things which will be covered: thalassemia, sickle cell anemia, leukemia, metastasis from neuroblastoma, bone lymphoma, mastocytosis, plasmacytoma, multiple myeloma, myelofibrosis, LCH, Gaucher's disease, hemophilia. So here you are. Candidate 1, over to you.
I'm presenting X-ray hand. I can see a diffuse expansion of all the pharynx and metacarbopharyngeal bone. I can. This is maybe expansion of all the bones. This is will be metabolic. Maybe maybe hypoparathyroidism due to reduce the osteopenia, generalized osteopenia associated with this expansion.
So you think that there is usually expansion of bone in hyperparathyroidism?
Osteopenia and thinning of the cortex could be there in
So
hyperparathyroidism.
something is happening in the medullary cavities, which is
Oh,
causing this expansion. That is a hint from my side. What comes to your mind?
maybe extramedullary hematopoiesis. Like sometimes it's
You
expanding.
see the word extramedullary hematopoiesis,
I
hemophilia.
mean medullary active bone marrow
So give me the
in
diagnosis. Give me your diagnosis.
this is active bone marrow in uh, active bone marrow in blood in chronic hemolytic anemias.
Okay. So this is a case of thalassemia. This is a case of thalassemia.
Okay.
And in thalassemia, what happens is that, there is actually the patient or the physiology goes in an overdrive and start producing red blood cells everywhere. So, and these are children. So that is why every bone is more or less involved. If you remember your pathology, you can make your radiology. So what will happen is that there will be expansion of medullary cavity. Wherever you find manifestation, you will find expansion of the medullary cavity. And the bones, they will lose their normal tubulation. So in this case, this was the case. You can see, if you see, there is expansion of all of the medullary cavities. There is coarse trabecular pattern, and if you see, loss of tubulation is there, and all metacarpals as well as the phalanges are involved. This is another example in which you can see the same thing. If you see all of the metacarpal as well as the phalanges, same finding is there, and to a lesser extent, the findings are also in the radius and ulna. Yes, madam, over to you. Describe the findings.
I am presenting a skull radiograph, lateral view. I can see over expansion of the extra of the outer table of the give sun ray of the skull, giving sun ray appearance. This is also related to thalassemia, one of the thalassemia or chronic hemolytic blood, the hemolytic anemia. Um,
Okay, let me take over. Now, in this case, this is again thalassemia, but look at the findings. What is happening is that the diploic space is thickened, and they give this classical sun ray appearance, as the candidate pointed out, or we also call it hair on end appearance. With that, if you see here, one of the fine touches that in the medullary cavity of the occipital bone, usually there is no hematopoiesis. So that is why that is deficient here. This finding is deficient here. Then look at the paranasal sinuses. This is a 11-year-old, and the paranasal sinus is obliterated. If you describe it in your exam, the examiner is going to give you marks on the basis of your description and the findings. So you have to tell the examiner that there is complete obliteration of the maxillary sinuses. And this CT, which is from another example, tells you what happens. There is so much expansion of the bone that there is complete obliteration of the maxillary sinus, which is lost. And on a plain film, it will be seen like this. So this is a different patient. This, of course, is a different patient. So this is again a case of thalassemia. Yes, madam, over to you.
I'm presenting a chest radiograph. I can see a widening of the mediastinum in the paravertebral with the paravertebral line obliteration. There is also related expansion of the expansion of the ribs. This is, I think, this is the. There is also a retrocardiac mediastinal lesion mass. Posterior also because it's overlap. It's the cardiac border could be seen. This is maybe extramedullary hematopoiesis with expansion of the I think expansion of the bone of the ribs.
I've given you a lateral view. What are your comments on the lateral view?
I can see the lateral view. I can see posterior mediastinal well-defined lesion. This is with the loss of black lower black sign. This is posterior mediastinal. Maybe also a differential diagnosis will be extramedullary hematopoiesis if the patient has a history of trauma. It could be also a hematoma. Also, maybe it's could be as it's rounded in shape, then maybe it's either bronchogenic cyst or a duplication cyst. This is mediastinal, mediastinal differential diagnosis.
Okay, let me take over. Now, if you see here, the findings here are that on this PA view, there is paravertebral soft tissue, and on this side, there is around in the retrocardiac, so there is paravertebral soft tissue. The candidate well picked up. If you see the ribs, for example, compare this rib with this rib, you will agree, though the exposure is not very good, but there is expansion of the ribs. Now, expansion of the ribs with this finding, your mind should immediately go to extramedullary hematopoiesis. But in the exam, if you don't pick this finding up, you are looking at a paravertebral mass. So they can still show you a lateral chest X-ray. Please remember this, that in the exam, they can still show you a lateral chest X-ray. In the lateral chest X-ray, the learning points are that if you open your Chapman and try to revise the position of mediastinal masses, on a lateral chest X-ray, we are quite good to discriminate. We have got groups, area 1, 2, 3, and according to that, the differential diagnosis changes. So, candidate, you bronchogenic cyst. This is not an area of the bronchogenic cyst. So later on, if you can go back to the book and see bronchogenic cyst, which part, I don't have that slide right now, so I cannot show you, but bronchogenic cyst is not in the differential, and this is what the exam is about. If you see on a lateral film in the posterior mediastinum, there is this area 1, there is 2, and there is 3, region 1 or region 2 and region 3. And there are specific things which can be considered. This is posterior mediastinal mass in an adult. And extramedullary hematopoiesis is one of them, and neurogenic tumor is another one, and there are some others. like lymphoma and myeloma and metastasis. In children also, this is in children. If you see posterior mediastinal masses, and again, extramedullary hematopoiesis is there. In our case, it was a unifying diagnosis. So, where once you pick up expansion of the ribs and this, you can be quite confident. And of course, if the examiner wants to show you on a lateral, they will show you. If they want to show you on a cross-sectional image, they will show you. Look at another example. And in this example, the main point is expansion of the ribs. You don't see, a paravertebral mass, as in keeping with the extramedullary hematopoiesis, but look at the ribs and how expanded they are. How expanded they are. This is also known as rib within a rib appearance. So some people use this word for, case like this. If you look carefully, look at this. There is a rib here and there is a rib here. So rib within a rib appearance. So that can be seen in thalassemia. Madam, describe the findings. I've given you the diagnosis. You describe the findings.
This is I can see expansion of the metaphysis of this is first it's knee radiograph frontal view for skeletally immature patient. I can see expansion of the distal metaphysis of the metaphysis with slight sclerotic changes seen in the medullary cavity associated with the thinning out of the cortex. The physis, I think it's maybe it's due to this is due to the age of the patient. Yani it's quite narrow physis.
I am trying to. I'm waiting for you to use a word for this. What is the shape of?
This is iron flask. I know the word, but I can't.
Okay.
I don't know how pronunciation. It's iron flask shape.
Okay, that's fine. Thank you. So this is what we call an Erlenmeyer flask deformity. And in your laboratory, all of you in your A levels and GCSE must have used this flask in chemistry and experiments, etc. So this is Erlenmeyer flask. And on this, when there is a femur, which the distal metaphysis is expanded, we use this word. And there will be a differential diagnosis. Even here, there is no stigmata on this film for you to confirm that this is thalassemia. So the examiner is going to ask you, what else can it be? And the main thing which you must remember, other than these rare disorders, osteopetrosis is one of them, where the bone density will be increased. Thalassemia, Gaucher's disease, and lead poisoning. And by the way, Gaucher's disease, thalassemia, and lead poisoning is in our today's curriculum. Of course, osteopetrosis will be high density. So you can say even here that it is not osteopetrosis, but you can consider it in the differential diagnosis. Okay.
I'm presenting an X-ray radiograph of hip joint skeletally mature patient. I can see the left head of femur is showing irregular cortical outline. This is with narrowing of the joint. Maybe there is narrowing of the joint space. And sclerosis. There is also generalized sclerotic changes seen in all the bone, all the visualized bone. This is maybe the left also there is sclerotic changes, but less evident than the in the other hip joint. This is
Conclusion.
maybe AVN changes,
Yeah.
avascular necrotic changes of the hip joint, more on the left side.
Okay,
Differential.
that's fine. Thank you. Thank you. Okay, well done. So these kinds of films, they do come in the exam. They can come in the rapid reporting also. So this patient has got bilateral findings, and we can see that on there is bilateral avascular necrosis and more advanced on the left side with sclerosis and some collapse, and there is sclerosis. So now, the hint here was, of course, it is not just confined to Africans, but it is more common. So, this, the hint is that something is wrong, and this is a case of avascular necrosis. Now, key points to remember in sickle cell correction, this was avascular necrosis secondary to sickle cell disease. Now, in sickle cell disease, I just want you to remember these. This will give you an idea of frequency of involvement. So, femur is involved in 96%, most common, and then is humerus. Hands and feet can be involved in 20 to 50%, and spine in 43 to 70%. So femur is one of the most common things. Please also remember that in avascular necrosis, in sickle cell disease, there can be what we call secondary infections. And beware about that. There will be double findings, avascular necrosis, and there will be infections. Now, this is candidate one, spot diagnosis. What's happening? Give me the description of the spine.
This is a description. This is H-shaped vertebra, diffuse H-shaped vertebra of all the visualized, most of the visualized dorsal spine. This is maybe for sickle cell anemia is one of the most important diagnosis.
Okay. Thank you. So what is happening here is that on this AP view, in the exam, I am showing you an X-ray which is very penetrated. It's sort of a bone type of exposure. So you can see it very well. In the exam, it will not be like this, and there will be more subtle findings. When you pick it up, then you will ask the examiner, I want to window it, and they will allow you to window or will window you it for yourself. And you can see, for example, here that there is a H-shaped vertebra, multiple H-shaped vertebra. This is quite classical for sickle cell. On a lateral, it becomes much easier, and you can see this depression here and depression. Classical Viva question. Why does this, the central portion, it depresses and these ones do not, giving you the H-shaped vertebra? And the answer to that is that in this region, the blood supply is the small arteries. There are end arteries. On the other hand, at the edges, there is an overlapping blood supply. There are collaterals. So that is why in the central portion of the vertebra, because of sickling, there is avascular necrosis and there is collapse. So on a CT scan, this is how it will look like. This is a different case. This is a different case. And of course, as a diagram, this is how it will look like. In your book, there is a differential diagnosis by the multiple collapse vertebrae and sickle cell anemia characteristic step-like depression centrally in the end plates resulting in H-shaped vertebra. So that is it. Another case of sickle cell anemia in which if you see the sclerosis, it is more marked. And the sclerosis is not just involving the head of the femur, where head of the femur is involved and there is subchondral cystic change. But if you see the bone density, it is, quite diffuse. It is somewhat patchy because here the bone density is normal. It is not completely diffuse, but it is quite, sort of a hybrid type of a model. So this patchy increased bone density can happen also in sickle cell. And you can see all of this. It is the same pathology which is happening, avascular necrosis. Now, this is a classical viva question. If you get this is a scenario in the exam where you pick up a subtle finding and then you tell the examiner that I want to confirm it on an MR, and they will show you this MR. And on this MR, uh, there is a what we call a double line sign. Question for candidate one. Double line sign is seen on which sequence? Question mark.
T2.
T2. So this is a T2 weighted sequence. Can you explain? So if you see here, there is a line here just superior to my laser pointer, which is slightly low signal. And then there is a higher signal line. This is known as the double line sign. So the first line, which is dark line, how do you define it? What happens here?
This is kind of osteochondritis dissecans. Then a part
Okay, so
of
what is this high intensity line?
this is sclerotic changes due to the detachment between the two parts of the bone, and the line, the hyper intense signal in between these two lines is the edema of the separated line of
Okay,
separation between the dead bone and the sequestrum and the revived the survived bone.
so these two lines, the answer is quite simple. The first line is the interface between normal and abnormal bone. So from here, the infarction, that the avascular necrosis that commences. And the second line, the high signal intensity line, is because of granulation tissue. Granulation tissue is the interface. In this area, corresponding to this area, variable intensities can be seen according to how much fatty marrow is there and things like that. But the definition of double line sign I've just told you, interface between normal and abnormal bone, and this is the granulation tissue. Okay, other examples of avascular necrosis, and if in sickle cell disease, and if you can see here, uh, there is secondary OA. Look at the glenohumeral joint. It is completely irregular, and maybe a subchondral geode is present there. Now, on the other hand, here you can see a lot of patchy, you know, uh, calcification, which extends into the medullary cavity. Now, here I want you to uh, differentiate between the term AVN, avascular necrosis, versus infarction. So the key point is avascular necrosis. Actually, it's just we have created this difference. Pathologically speaking, there is no difference, but the convention is when the epiphysis is involved, the bone end is involved, we use the word avascular necrosis. And when metaphysis or diaphysis is involved, we use the word infarction. It is one and the same thing. So in infarction, metaphysis and diaphysis will be involved. Now, look at this. These are multiple bone infarcts. And in these multiple bone infarcts, uh, you can see this calcification. Just 1 second, please. So there is calcification. Now, this calcification, you should have a clear-cut idea about the shape of this calcification because that per se becomes an exam case. So before I come to the calcification, see the MR. And on MR, you can see this, bone infarcts which are extending into the metaphysis and diaphysis. And so the calcification usually is at the edge of the infarct, giving you this serpiginous type of calcification. This is the word which should be in your vocabulary. Serpiginous, look at the edge. This is a cadaveric X-ray. This is a cadaveric X-ray. And you can see this, look at it, it is at the edge. And look at this MR and this calcification corresponds to this. Why is this differentiation important for your exam? It is important for your exam because of this. This is a cartilaginous tumor, namely enchondroma. Enchondroma. Now, please remember that enchondromas or cartilages, this is a benign tumor which is when it is in the long bone, it has got cartilaginous matrix. On MR, cartilaginous matrix is high signal on T2 weighted sequence. But on X-ray, cartilaginous matrix shows calcification. This calcification is so dense that it projects through the bone. Now, what the learning point is the shape of this calcification or the pattern of this calcification. These words should be in your vocabulary. This calcification is ring shape. They are rings, arcs, punctate. Punctate is like dots, and flocculent, tufts of wool. So these are the words to be used. Ring and arc is the most common. Point to remember is that an enchondroma will have this kind of calcification. A bone infarct will have a serpiginous type of calcification, usually. And this is how you discriminate, because both of these conditions can show malignant transformation, both of these conditions. And the pattern of calcification will tell you what was the parent lesion. And that will become a classical exam case. I think I teach you these films when I teach bone tumors, chondrosarcoma, etc. So, but here the learning point is the vocabulary and how this calcification looks like on a plain film. Now, beware of sickle cell anemia with osteomyelitis. And all these films which are in front of you, all these examples can be film in the exam. Look here what's happening. If you look carefully, you can see this cortical breach here. And there is a lot of soft tissue thickening. So it looks like an aggressive lesion. So this is, small bones, dactylitis, and even in sickle cell disease, there can be salmonella osteomyelitis. And look here, there is a permeative type of bony destruction. There is soft tissue, periosteal reaction. If you handle it in the exam, you will describe it, and then you will say that this is an aggressive lesion. And the aggressive lesion, the differential, of course, will be infection or a malignant tumor. In this age group, even sarcoma will be top. This one is a better example for the exam because you can see multiple findings. If you see here, look at this metatarsal and look at the soft tissue swelling. And then you can see sclerosis here in the first metatarsal. So there is avascular necrosis here, and there is secondary infection or osteomyelitis here. And sickle cell can involve everything. Candidate 1, over to you.
I am presenting chest, I am presenting abdomen radiograph frontal view. I can see H-shaped vertebra in the L4, especially in L4 vertebra. Also, there is a vascular, there is a radiolucent area seen in the left head of femur. The right head is showing prosthesis, showing prosthetic, total hip replacement prosthesis. There is a calcification seen on the upper quadrant, left quadrant at the site of the anatomical site of the spleen. This is maybe maybe calcification in the spleen as it's autosplenectomy, auto infarct, and autosplenectomy. There is a enlargement, I think, in the shadow of the liver at the
Okay,
site.
madam, so what is your conclusion?
My conclusion: this is maybe a case of sickle cell anemia.
Okay, thank you, well done. So this is a classical case for the exam. We call it a story film. This is, in 2B, story films, if an examiner has them, they show it. The story is here that as the candidate pointed out correctly, that calcified spleen means autosplenectomy, also H-shaped vertebrae, and then uh, the story is that this must have had a avascular necrosis with secondary, hip transplant. So this is sickle cell disease story case. Another example of a story film where, if just consider yourself in the exam and you get it in the exam, and you describe everything, maybe some sort of head shape here, but not as obvious as we had seen in other films, the earlier examples. But then you see that sclerosis in both of humor, and then look at this finding. The gastric bubble is shifted here. Usually it will not be here, it will be here because of the spleen. So means there has been a splenectomy. So this finding, if somebody picks up in the exam, the examiner is going to give you some marks for that. So, but this you will only see once your mind goes into this, that this is sickle cell. So the mind, the eye see what the mind knows. Example on a CT scan of a autosplenectomy, where it is totally infarcted and calcified, very small spleen. Okay, madam. Maybe this is your last case. Okay, I'll give you one or two more after this also. Yes.
Okay, I can see multiple. This is bilateral knee radiograph. I can see mixed lytic and sclerotic changes seen in the medullary cavity associated with the physeal regular shape and the reduction in the size of both faces of the tibia. There is, I think, there is in the this is the left fibula. There is a line. Maybe this is fracture line. I am not sure. Seen in the distal end of the proximal end of the fibula. This is a conclusion. This is serpiginous. I think in the tibia there is a serpiginous changes in the metaphyseal sclerotic.
So what is your conclusion?
This is maybe also the same as sickle cell anemia. I think.
Okay. Thank you. Now, this is a case of leukemia.
Leukemia.
And if you see the findings, first of all, the findings. Now, look at the metaphysis. This metaphysis is abnormal. This 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 is abnormal. So there is a metaphyseal abnormality. Then see the pattern of the abnormality. It's very moth-eaten type of appearance. It's not, it is very aggressive looking appearance. Look at here. So now we go into the differential diagnosis of so here the word is written solitary radiolucent metaphyseal band, but it can be, slightly different also. Now, look at this: leukemia, lymphoma, metastatic neuroblastoma. So in these conditions, the metaphysis is involved, and you have to remember this. So the differential diagnosis which tallies with this case is metaphyseal lucent band. And this is another example of more conventional. That one was very aggressive. Look here, there is metaphyseal band, metaphyseal band, metaphyseal band. So if you know, once you pick up this finding, then the viva will be, what can it be? What else can it be? And usually in this age group, leukemia versus metastasis, from neuroblastoma, it's very difficult. And both of them have got a lot of overlap, leukemia and metastasis from neuroblastoma, metastatic neuroblastoma in peds. So even in the skull, they have got findings which are quite similar. Just to make a point, this is another case of leukemia where it is involving the diaphysis. There is this thick periosteal reaction, some lamellar periosteal reaction. If you look carefully, there is permeative bony destruction. This is normal bone, this is abnormal, this is normal, this is abnormal. Where is the zone of transition? It's not very clear. So candidate one, thank you very much. I think your time is, yes, your time is up. Well done.
Thank you.
Okay, candidate two, are you with us?
Yes. Good evening, sir.
Good evening. This is your first case.
Okay. I have been presented with baby gram for skeletally immature patient. I didn't catch anything obvious, so I go through my checklist. First, I will check the both lungs. I can see that both lungs appear clear. However, I can see that there is expansion of the ribs seen bilaterally. There is no expansion in the spaces between the ribs. I'm now checking the vertebra. In my routine practice, I will also change the window for this radiograph to see if there is any abnormality within the vertebra, which I cannot see. Second of all, I cannot see any abnormality within the both clavicles and also both the humerus and also the forearm bones. Regarding the abdomen, I cannot see any obvious pathology within the abdomen.
Review the right humerus.
The right humerus, okay. Regarding the right humerus, I can see that there is lytic area seen in the proximal aspect of the right humerus. In my routine practice, I will also zoom this image or see if there is any right humerus dedicated radiograph. I cannot.
You also have got this X-ray for the same patient.
Yes, in this radiograph for both knees, I can see that there is enlargement of the distal metaphysis of the both knees, also associated with sclerotic bands in the both distal metaphysis of both femur bone. Also, I can see that there is sclerotic band also seen in the proximal metaphysis of both tibial bones.
Okay,
I can see.
what is now till now? What is your differential for all of this?
Yeah, I will look for the differential diagnosis for sclerotic bands in the metaphyses. First, I will think about poisoning, such as lead poisoning. In some cases, it could be normal. Other differential diagnosis, it could be due to hypervitaminosis.
So you are actually you are describing this sclerotic band. What is happening here? What is
Here I
happening
can,
here?
yeah, I can, yeah. I think these are two areas of uh, lytic lesions
Right. So
seen.
there are lytic lesions,
Yeah,
and you have seen lytic lesion upstairs in the humerus also. So what do you think? What are you now thinking?
um, according to the patient age, is skeletally immature. I will think about metastasis. It could be due to metastasis from neuroblastoma tumor if the patient is known
Okay.
case.
Now this is the X-ray of the patient. Look at the abdomen. What do you
Yeah, I
think?
can see that there is uh, enlargement seen in the left upper quadrant that extending toward the abdomen. It could be due to
What
neuroblastoma
will we
tumor.
do next? What will you do next?
I will ask for ultrasound for this patient.
Here you are, ultrasound.
Yeah, in this ultrasound, there is multiple images. I can see that there is well-defined mass lesion. In the second image on the right, I can see that the lesion is seen inferior to the liver because I can see the intrahepatic biliary. So this is the liver. So there is a mass lesion seen inferior to the liver, and
And
this could,
conclusion, your conclusion,
yeah, it could be due to neuroblastoma with bony mets, or it
or
could be due, well,
or
or it could be Wilms tumor.
so Wilms tumor. Why did you say Wilms tumor? You can see this kidney here.
Ah, yeah, yeah, yeah. Yes,
See
yes. It
this,
is neuroblastoma. Yeah.
right? Okay. Now look at this. This is a classical exam case. It's from our departmental teaching files, very old film, and we have scanned it, and it was a hard copy. But this is classical 2B stuff. What we see here is that there is this erosion of the metaphyses. Actually, it's not projecting for you very well, but there was erosion here also. But on this scanned copy, I think it's not projecting for you very well. With that, you can see that there is some sort of soft tissue here. So on this film, this is it. So your review areas that what is happening here. Even with this finding, you should have gone for an ultrasound. Now, with this, now one teaching point which I want to tell you is that the candidate confuse this thing, this high density at the metaphyses with lead poisoning. And which is very good that this confusion was made because this is how you learn. Now, please remember that dense metaphyseal band is a different differential diagnosis in your Chapman. Dense metaphyseal band. And there is a lucent metaphyseal band, right? Now, dense metaphyseal band, it is usually, uh, it can be normal, physiological. Every child will have this dense metaphyseal band. Key finding is that usually this will not involve the fibula. This is a key exam finding to remember. Even in lead poisoning, they will show you lead poisoning case where the dense metaphyseal band will also involve the fibula. The physiological ones, they don't involve the, because there is no weight bearing there. So good that we have gone into a different, but otherwise the main finding here is that there is lytic lesion, erosion, maybe a developing erosion here. This is a classical case of mets from neuroblastoma and classical exam presentation. And you can see this is superior to that. Okay. Yes, candidate two. Normal, abnormal. What do you think?
This is abnormal radiograph.
How do you describe this? I'm looking for a word in your.
Yes,
Hmm. Please.
mouth-eaten appearance.
Excellent. What is your differential?
I'm thinking about aggressive process that involve multiple bones. I was thinking about leukemia or lymphoma.
Excellent, excellent. Now, the idea to show you this case was to develop your eyes on this moth-eaten bone in a child. And moth-eaten means it is completely abnormal, whole diffusely abnormal. And remember, it's a child. And the differential diagnosis, the most common is neuroblastoma mets, leukemia. These two are the top. Your lymphoma, of course, can be there. So the idea is now, is this a moth-eaten bone? Candidate two.
No, this is not mouth-eaten bone.
Hmm.
I think the other one, the previous one, is more typical for mouth-eaten bone.
So what is this?
This could be like a metabolic disease because
Which
I can see
metabolic
that
disease?
what
Which metabolic disease you are talking about?
this is a patient of old age, so it could be due to Paget disease because I can see that there is expansion and trabeculation of the bones.
Excellent, well done. So the idea here was to show you a case of diffuse Paget's disease. And if your eyes are not developed, then you might, okay, what is happening? It is also moth-eaten. No, it is not. In Paget's disease, by the way, first difference is the age difference. This is a child, this is an 69-year-old. Even if I don't tell you, you can understand that this is an old age. And there is expansion, coarse trabeculae with expansion of the bone. So don't confuse this appearance as if there is a destructive process. Another example from neuroblastoma, and you can see, the moth-eaten appearance, which is more typically, more obviously involving the metaphysis, but it is more diffuse process. Now, metastasis from neuroblastoma, they will show you skull X-rays. Remember this, skull X-rays, in which there will be destructive lesion like this one, where there is some thickening and some soft tissue, and mets from neuroblastoma versus leukemia, both of them, they can cause this. And this MR tells you actually the pathophysiology, and you can make the radiology. Basically, the metastasis has involved, it is a dural metastasis. From there, it has gone into the skull also. And this is another example where we can see that there is a dural mets and which has gone into this sphenoid, lateral wing of the sphenoid, and causing this secondary bony destruction and host reaction. So skull X-ray also is in the same category. Okay, normal, abnormal. Candidate two.
Normal or abnormal? Okay, let me check.
Yes. Let me open it for the chat. Normal or abnormal? I'm looking at the answers. If it is abnormal, give me the finding. So it is open for the chat also. But candidate two, if you pick up the abnormality, just tell me. I will not take abnormal as an answer. I want you to point out the abnormality, then right femur lytic lesion, no. Iliac, okay, good, well done. Now, somebody has picked up iliac. Now, look carefully. This is a classical exam film, In rapid reporting, it can also come in the Viva. Now, if you look carefully, look at this iliac. In pelvis, key thing is to compare right and left side. Somebody who was comparing right femur with left femur, well done. So that's the good way to. But if you see, you can look at this area, look at the trabeculae, then look at this one. It's a definite finding. It's not as, it is subtle finding, but definite. So this is the type of case which you have to develop your eyes for the exam. I'll show you 3, 4 like this today. So by the way, this was lymphoma. So the idea was to show you lymphoma. What I want to tell you about lymphomas on plain films, that lymphomas can also be sclerotic. Just remember that. And this was a lymphoma. There was previous surgery which has gone into the bone also. And this was sclerosis. That was the point. Look at this lymphoma. Now, I will describe it for you, and then candidate 2, I will ask you a question. And on that question, I will give you a mark. Now, if you see here, it's an aggressive lesion. Look at this cortex. This cortex is thickened. There is periosteal reaction. And this, this is on the other side. There is something in the here, if you look very carefully, develop your eyes on this thing. Where I am pointing out, you will see end ostial scalloping, subtle end ostial scalloping. What does it tell you? Look at this cortex versus this cortex, and you will agree that there is end ostial scalloping. These words should be part of your vocabulary. End ostial scalloping, periosteal scalloping. If something is sitting outside and causing indentation of the outer cortex, you will call it periosteal, and this is scalloping, and this is end ostial scalloping. Now, with that, there is some high density. Look at this. Candidate 2, what is this? What is this?
The high density?
Yes, the high density. This arrow, this arrow.
It could be, no, it's not calcification. Sorry, I don't know.
So yeah. You are close to it. How will you call it? Because I'm going to give you a mark
Dense.
for this.
I will call it a dense lesion.
Okay,
Sclerotic.
suppose it was. I tell you that this is a case of osteomyelitis. What do you call it?
Follicular.
No, in Volicurum is something else. This is what we call sequestrum in a, right?
Yes.
Now, sequestrum by definition is a dead bone, and there will be films. Now, concentrate on this. Sequestrum is a dead bone in a case of osteomyelitis. So, in a chronic osteomyelitis, what happens is that in a chronic osteomyelitis, these words should be in your vocabulary, which is dead bone, which is this bone, is known as sequestrum. Please remember, this is a very important finding from a clinical context, but because if there is a dead bone lying there, it will not heal. You have to tell the clinicians that there is a sequestrum there. And it is very sclerotic because it is dead bone and there is no osteoclastic activity going on. Now, involucrum, of course, is this thickening of the periosteum, and there can be cloaky. Now, in classical 2B world, bone sequestrum can be in other pathologies other than osteomyelitis. And this is what the 2B films can come in your viva. And please remember this differential diagnosis. Osteomyelitis, everybody knows. In TB also, it can happen. LCH, this is a very important exam case. LCH, eosinophilic granuloma, I'll show you. And lymphoma can also have sequestrum. Malignant fibrous histiocytoma is such a rare tumor that nobody will show you, but they will grill you. Particularly, this has come in the exam quite a few times, this eosinophilic granuloma. Of course, a mimic is an osteoid osteoma, which is gives you a sequestrum type of appearance, but where is it? It is in the cortex. It is not in the medullary cavity. So look here. This is in a case of osteomyelitis. This is a classical exam case. This is sequestrum in a skull X-ray. Now, if you see this lucency, and I'll come back to this details of this lucency when we cover LCH. In the middle, there is a high density material, and this is what sequestrum is about. This CT is of a different case, by the way. But just to make a point that there is a sequestrum there. Please remember that sequestrum can be, so this can be chronic osteomyelitis, and this can also be LCH, Langerhans cell histiocytosis. So remember this. And this is the mimic we were talking about. This is the osteoid osteoma, but osteoid osteoma will be in the cortex. It will not be in the medullary cavity. That is why we are using the word mimic. So this is once again your case in which you can see this aggressive lesion, and with that, you can see sequestrum. So in your exam, if you tackle it like this, that, this is osteomyelitis, I'll take it. Of course, I'll accept it. But then I will ask you, what else can it be? So now you have learned that sequestrum can also be in lymphoma. Usually lymphoma of bone is in diaphysis. So this is just to make a point that lymphomas, the soft tissue component can be very, just like an Ewing's, etc. It can be very thick. Candidate 2, what are the key 2 sequences for marrow imaging?
T2 and STAIR.
T2 is incorrect answer. For marrow imaging, the key sequences is a T1 and a
T1.
STIR. T1 and a STIR. And anything which is low on T1, because the fatty marrow is destroyed. Please remember, usually on a T1 weighted sequence, fatty marrow is bright. And fat is our friend there in the bone. And if you lose fat, means problem. And but then comes the fine touch that it should be lower than the adjacent muscle or lower than the adjacent intervertebral disc in the case of spine. Now, whenever you see something which is low on T1, next sequence you have to look is the STIR sequence. Anything which is low on T1 and high on the STIR sequence means, means trouble. It can be infections also, but it can be tumors also. What do you think about the bone density here?
The bone density, I think it's increased in bone density.
Okay, so this is a CT of the same patient, and even in the spine, the bone density is increased. Even on the CT, we can see that the bone density is generally increased. This is a single image of the abdomen. What is your finding and what is your differential?
In the CT scan, I can see that there is diffuse sclerosis of the vertebral bodies and also pelvic bones, also involving the proximal both femur. I can see in the axial images there is perihepatic ascites. I can see that there is splenomegaly, and it could be hepatosplenomegaly. In my routine practice, I will check the rest of the images. And
and there is some lymphadenopathy also. Now, lymphadenopathy. Now, what comes to your mind? This is 42-year-old.
I'm thinking about disease such as mastocytosis or lymphoma.
Excellent. Well done. Okay. Now, something about mastocytosis. What is mastocytosis? Mastocytosis is a rare, and this is from your Chapman, rare myeloproliferative disorder of mast cells. The cutaneous form usually presents with skin rash. The less common form usually presents or can involve multiple systems. And that is why they will ask you in the 2B exam. Bones is a common site, and generalized increased bone density or localized increased bone density, it can cause focal sclerotic lesions, and it can cause diffuse sclerosis also, and hepatosplenomegaly, lymphadenopathy. Of course, in GI, etc., they can cause many things, like ulcers and mucosal thickening in the small bowel. And if you read the differential diagnosis in your books in GI, I'm not going to show you GI today. What we call mucosal thickening in the small bowel. Mastocytosis is one of the conditions. Peptic ulcer, diffuse small bowel thickening. Now, so the key thing here is the differential diagnosis of diffuse sclerosis, increased bone density, or multiple sclerotic lesions. So this one is another example from literature where there is sclerosis of the femur, vertebrae, and even in the cervical spine. And this is another one. So even if you get a solitary dense vertebra like this, solitary, mastocytosis you should consider, and also lymphoma you should consider. I just told you a while ago. Yes, candidate 2.
I have been presented with frontal pelvic radiograph for an adult patient. The main abnormality, I can see that there is expansion of the right superior pubic rami and also associated with a lytic lesion. I cannot see the outer cortex of this bone completely. So it could be there some sort of erosion. In comparison with the left side, the left superior pubic rami appear normal, not expansile, and there is no lytic lesion. Regarding the rest of the bones, I cannot see any similar bony lesion. So the conclusion, I have got solitary expansile lytic bony lesion. My differential diagnosis for this, it could be due to metastasis, especially if the patient is known case of malignancy. Other differential diagnosis, it could be due to multiple myeloma.
Okay. Now, this patient is 42 years old. Now, look at the internal architecture of this lesion. I want you to use a term, use something, what I use, it should be in your vocabulary. How do you describe this lesion?
It's look like bubbly appearance.
Bubbly, oh, very good. So soap bubble appearance.
Yeah.
Excellent. Soap bubble is the word which we use. And when there is a soap bubble lesion, what is your differential? You talked about metastasis. So metastasis from what? This is the next 2B question. This is a classical Viva question.
First, I will think about renal as a metastasis. Lung.
No, soap bubble. So renal is a correct answer. Second one is thyroid.
Thyroid.
Yeah, okay, let me take over. Well done. Now, if you see here, this is a classical soap bubble lesion. And this is the fine touch in the exam, where you see a soap bubble lesion. Now, if you see the soap bubble means that there are multiple internal trabeculation, as if there are multiple cystic, cysts inside the lesion. It is causing expansion. Please remember, there is no need of, when we describe a tumor in the long bone, one of the key parameters to differentiate that it is an aggressive lesion versus a non-aggressive lesion is zone of transition. But in the axial skeleton, like pelvis, that doesn't work. So, a narrow zone of transition can be malignant and can also be benign. So remember that. In your description of a tumor in a long bone, zone of transition is a very important point. In axial skeleton like pelvis, it is not. Now, you have got a soap bubble lesion. Now, take a screenshot of this. I don't think so it is in your Chapman. Two things I want you to remember. Soap bubble, it is plasmacytoma, 42-year-old. I'll come back to this shortly. Multiple myeloma, usually the age group is more. Plasmacytoma, metastasis, and this is a classical 2B question where, which metastasis, RCC and thyroid. Even they can give you a long case where there is a ultrasound of the thyroid with a soap bubble lesion. So, or ultrasound of the kidney and a soap bubble lesion. Then these differentials should be in your mind: giant cell tumor, chondrosarcoma, fibrous. Look at this, fibrous dysplasia can also give you a soap bubble appearance. It's a benign thing, chordoma, that is in the sacrum. Now, this differential should also be in your mind. Very important for the exam. So lytic lesion in the pelvis, Mets and plasmacytoma, and this is the way to remember things. You just sort of in one page you remember both of them, and there is a bit of overlap. And then other than plasmacytoma, multiple myeloma, I'll tell you very shortly what is the difference between the two. And then lymphoma. So lymphoma cannot give you a soap bubble appearance. This is the point to remember. And then giant cell tumor, chondrosarcoma, these are all common. So this is lytic lesion and this is soap bubble lesion. So there are, in the exam, they will show you cases in which there will be 2-3 differentials. At times, they will show you cases in which you can just give one diagnosis. And this is what this exercise is about. Now, the word soap bubble, this is from Radiopedia. Soap bubble appearance, multiloculated bubbly appearance. And this is what the candidate also used this word. So, and in other bones, so we were talking about the pelvis here. And so, for example, an adamantoma or a mieloblastoma of the jaw is also soap bubble. Right. Now, plasmacytoma versus multiple myeloma. So this concept should be in your mind that what is a plasmacytoma? It is localized clonal proliferation of plasma cell. Solitary bone plasmacytoma. Look at this word. It tells you that this is a single lesion. And by the way, it can then degenerate into multiple myeloma. So then there is solitary extramedullary plasmacytoma. So sometimes the plasmacytomas can be outside the medullary cavity. And there can be plasmacytoma with multiple myeloma. This is histological differentiation between the two. A bit of recap about red marrow. In a baby, in an infant, whole of the marrow is red marrow, and RBCs are produced everywhere. In an adult, this is the axial skeleton where the red marrow is present, and the proximal femora are still producing red cells, and maybe proximal humerus also. Now, this is from your Chapman, and read it today: multiple myeloma versus plasmacytoma. Now, look at this. I'm just going to read this for you. Plasma cell neoplasm of bone are either solitary. Plasmacytomas are 3% of all plasma cell tumors, or multiple diffuse, 94% of, or 3% of all plasma cell tumors are solely extraosseous. Always occur more than 40 years of age and usually associated with amyloidosis. Rest of the stuff, I'll show you a few cases to make the point. But as far as plasmacytoma is concerned, it will be in red marrow areas, and it will be lytic. 44% show multiloculated soap bubble appearance, 44%. And look at this, majority progress to multiple myeloma, 2 to 4 years. Now, key Viva question, and this is a question for you. So I'm not going to ask you the question, but just to let you know that this kind of a case, if it comes in the exam, I will say, you should actually tell the examiner that now I will advise more imaging to rule out multiple myeloma. And similarly, in the case of if it is a metastasis, of course, you will do more imaging to rule out multiple skeletal metastasis. Key point to remember, the practical point is that the diagnosis of plasmacytoma, of course, is based on histology or biopsy. But if radiologically speaking, you are calling it a plasmacytoma, in the same breath, you should ask for more imaging so that you can rule out a multiple myeloma. And why do you want to do it? Because a plasmacytoma, median time progression 2 to 4 years, it actually becomes multiple myeloma. And in many cases, uh, actually the presentation itself is multiple myeloma instead of a plasmacytoma. Now, here comes a bit of fine touch. Uh, what imaging modality will you ask for multiple myeloma? Candidate
Two.
two.
Yeah. For multiple myeloma, I would ask for bone scan or MRI, whole body MRI.
Will a bone scan show multiple myeloma?
No, sorry, I retract that. I think whole body MRI is better.
Okay. Now, just to make a point that there, in this case, there is a lytic lesion in the sacrum. And what is the differential? Top two for you.
It could be due to metastasis versus multiple myeloma.
Okay, you can also say plasmacytoma or multiple myeloma, or there is one tumor which occurs at the clivus and in the sacrum. You know, the
Yeah,
two
the
ends of the
chordoma.
chordoma. So the teaching point or learning point here is that when you see a lesion of the clivus, or you see the other end of the notochord, which is the sacrum, chordoma must be kept in the differential. So this was a plasmacytoma, but chordoma. Okay, now, can you describe this lesion for me?
Okay. I have been presented with a frontal radiograph for the pelvis. I can see that there is mixed lytic and sclerotic lesion noted within the left iliac bone. And this lesion, I think, showed the same soap bubble appearance that we saw before. This mass lesion showed narrow zone of transition without periosseal reaction, and I cannot see any cortical destruction.
Conclusion.
Due to the narrow zone of transition, absence of periosseal reaction, and no cortical destruction, I am thinking about benign etiology.
First of all, I told you that narrow zone of transition is not a parameter in the axial skeleton. Don't use it. For example, even here there is narrow zone of transition, and
Okay.
even yeah. So you use it in a what we call long bones, but margin of the lesion. These are two different terms, which I think I've taught you in tumors. When you describe, there are 10 parameters on which a bone tumor should be described. One is zone of transition, and second one is margin of the lesion. Here, look at the margin, describe the margin. Over to you. Margin of the lesion.
Yeah, I can see that the margin appear sclerotic and interrupted, which shows like areas of erosion,
What is your conclusion?
aggressive lesion.
Okay. Now, the point is that this is the fine touch, of what I use the word developing your eyes. This also is a sort of a soap bubble type of lesion. If you see here now, margin of the lesion. Now, let me go back to your original plasmacytoma, which was this one. Now, look at the margin. You see there is no sclerosis there. When there is sclerosis, means the lesion is not growing. You know, it's taken as a sign of a less aggressive lesion, but it's more than that. If you look at this sclerosis, where I am pointing out, it is thick sclerosis. Thick is the word. And
Mm.
this is known as rind of orange appearance. And this is another example where in fibrous dysplasia, this is what it is like. So I would like you to, these are the findings where you describe it, and then your thinking process that it can be, because of this, it can be fibrous dysplasia. On the other hand, look at this case. Now, in this case, there is a lesion there and there is calcification inside. What do you think?
Due to the calcification, I am thinking about aggressive lesion, such as chondroid matrix lesion.
Excellent.
That, yeah,
This is a
chondrosarcoma.
This is a chondrosarcoma. Fine. Now, plasmacytomas can sometimes cross the SI joints, and this point I want to highlight. Don't, they can simply cross from the iliac side to the sacrum. This is just a few films for rapid reporting. This one is easy, isn't it? Where are the lesions?
The lesion seen in the diaphysis of the humerus
Right.
bone.
So these are the lesions, and this now there is lesion here, there are lesions here, there are lesions here, and maybe some collapsed vertebrae. What will be your diagnosis?
Langerhans cell histiocytosis,
What is the age of this patient?
adult,
Which kind of adult?
elderly, could no, it's young,
55
young,
years.
55, yeah.
Look at this. Look at these joints. Why did you say Langerhans cell histiocytosis?
Because I saw there is involvement of the skull.
Yeah. So multiple lytic lesions. And
Yes,
what has been done? It's a skeletal survey.
survey.
So what is the diagnosis?
Because the patient is old age and skeletal survey, I'm thinking of between the multiple myeloma and metastasis.
Yeah. So this is multiple myeloma. Now here comes, in multiple myeloma, uh, is the most common primary bone tumor. Remember this. And it can be multifocal, it can be diffuse. Now, the imaging, this is what I was talking about, that bone scan is not sensitive for multiple myeloma. And it all depends where you are working and what kind of facilities your department has. But bone scan, you should never, this is what they are going to check in the exam. You should not ask for bone scan in multiple myeloma. So classically, they are lytic punched out lesions. Now, as far as imaging modalities are concerned, uh, uh, skeletal survey. In many countries, still skeletal survey is being done. When I joined my department here in Basildon in 2006, we were also doing skeletal survey for quite a few years. And the skeletal survey is cervical, thoracic, lumbar spine, skull, chest, pelvis, humeri, and femora. Total radiation dose is 1.7 to 2.4%. Please remember this thing. This is a big thing. What is the sensitivity of plain X-ray? Actually, up to 30 to 50% of the bone should be destroyed before you see something on a plain X-ray. So the false positive rate is quite bad. And this is an example where on a chest X-ray, sorry, on a pelvis X-ray, you can, this is from radiographics. Just see this versus look at the lesions on a MR. So bone scan, don't use it. That is the key point to remember. So limited use, it is useless. Don't in the exam also don't ask. They will ask you a leading question. Will you do a bone scan? No. Now in UK, now we are most of the departments, my departments including, we are doing whole body CTs, but many departments, particularly tertiary level, are doing whole body MRs also. It all depends where you are working and if you've got capacity to do it. So, and I'm sure in a few years' time, if we have got another scanner, we might, start it. So here, whole body CT sensitivity is this one, and radiation dose is usually double. But if you use low those protocols, then it will. European Myeloma Network and European Surgery recommendation is whole body CT. This is their recommendation because CT is available everywhere. Whole body MR is not, and you can see these lytic lesions in a CT. And otherwise, whole body MR, the key sequences are T1 and STIR. And if you want to add a diffusion, you can. It can add to your sensitivity. But otherwise, T1 and STIR are considered, sort of good enough. This is a whole body T1 and a STIR sequence. So this is on a T1 low signal and multiple lesions in the, this is a DWI sequence. Of course, PET CT can also be done. It is very good, but you will not have the capacity to do a PET CT for every case of multiple myeloma. I just wanted to tell you something about Dixon imaging here. And now in many departments, we are using it, Dixon technique. Dixon is a name of a physicist. I think he described this, it's a physics thing. He described it in 1984, but the hardwares which various departments had could not achieve this technique. And now most of the new scanners, they can use it. And it is a very useful technique for various, even in head and neck, even in liver, etc. People are using the same technique for contrast, etc. But just concentrate on what we call musculoskeletal imaging. In Dixon technique, and Dixon, I think he died very recently, 2022 or something. He's no more with us. He got some gold medals and things like that for this. So these are 4 sequences which we do in Dixon technique. This is a in phase. This is a out of phase. Just like in phase or an out of phase of a liver or adrenal. And you can see India ink artifact, India ink artifact. Look at this muscle and you will see the India ink artifact. In phase, post phase. Then the third image is fat only. Only fatty things, they show signal. And then is water only. So the fat is totally suppressed and anything which has got water will be seen. Now, the point to remember is that look at this lesion here, and then another one, and then another one. Now, what happens is in your day-to-day practice, and we are using Dixon more and more, suppose you get only this lesion and you are not very sure. It is low on T1 and on STIR. You are worried it is positive or negative for something. Go for a Dixon, and Dixon will give you a good idea. If it shows you high signal on this water only, means trouble. So this is Dixon technique, a new sequence. Just wanted to teach you this. Look at this one. This is from skeletal radiology. Now, Ian Presney is one of our DKT faculty members. He shared with me this. This is his study from Royal National Orthopedic Hospital. Look at this in phase. So on a T1 weighted sequence, there was a lesion here. Now, this is a very good example. And you are not very sure, is it normal or abnormal? You do Dixon. This one, only 2 phases have been give you the answer. This is an in phase, this is out of phase. Now, out of phase means it is blacker or darker as compared to in phase. What does it tell you? It tells you that it has got fatty component. Just like adrenal adenoma or a fatty liver, same principle is applied there. When there is fatty marrow inside, means it's a normal, and it was a focal nodular marrow hyperplasia. So just wanted to introduce you to Dixon technique. I do not think so that in 2B anybody is going to ask you, but times are changing and they might ask you in in future. But I also wanted to introduce it to you. Apply it in your day-to-day practice. It's a very good problem solver. Okay, normal or abnormal. Now this one is in the chat, for the chat. Normal or abnormal? Yes, please. If it is abnormal, give me what is the abnormality. Yes, please. Left, very nice. So there is a lytic lesion here. There is a lytic lesion here. Well done. Okay, in the chat, normal or abnormal? Yeah, good. Well done. Somebody has picked up right proximal femur. This is a classical exam case. You can see these trabeculae, which are normal, and then there is a lucency here. Look, compare it with this. So in the pelvis compared, well done. And this is a sort of a close-up of the same thing, and you can see that this is what it was about. Any abnormality? Normal or abnormal? Chat. Punched out lesions. Very good. So there is one here, and maybe one here and one here, but these two are quite obvious, punched out lesions. Now, you are reporting this CT scan, candidate 2. What will you do? What is the finding and what will you ask for?
I can see that there is abnormality seen in the in the right frontal area. I can see that like soft tissue area seen outside the skull in the front of the right frontal bone, and I can see that there is changes seen in the right frontal lobe itself. My next step, I will ask for post-contrast images.
Before that,
I will do bone window.
yeah, this was simple as that.
Yeah, there is multiple lytic lesions noted within the skull itself.
Yeah, that's
And
fine. Thank you. Thank you.
yeah.
So it's simple. You know, ask for bone window and the diagnosis is made. This was multiple myeloma, and that is it. Now, this is the marrow imaging we were talking about. I think I've shown you this case quite a few times in the past also. Just to repeat it, that the key sequences for marrow imaging is T1 and the stir sequence. In this patient, whole of the marrow is abnormal. If you look carefully, look at the thoracic spine, look at the marrow here, and compare it with the intervertebral disc, and you will agree that the intervertebral disc is slightly more bright than the marrow. Then compare it on the stir sequence, and on the stir sequence, diffuse high signal. And you have to develop your eyes on a normal skull. So let's see how a normal stir looks like. This is a normal patient. This is how a normal marrow is. It all depends on the age of the patient, and it all depends on the quantity of fatty marrow. But this is the fatty marrow, which is brighter as compared to the intervertebral disc on a T1. And on the stir sequence, the word stir is short tau inversion recovery. It's a fat saturated sequence. So the fatty marrow is saturated and the vertebra is dark, you know, and look at our abnormal vertebra. So this is the same case which I was showing you, and you can see here that it is abnormal. Compare this with this one. So this is diffuse abnormal marrow, and diffuse abnormal marrow is an important exam case because if you have not developed your eyes, you are not going to pick it up. This is a diffuse marrow abnormality of the whole spine. Whole spine because of CA lung metastasis. And you can see the same finding here. Just see this, compare it with the intervertebral disc. Intervertebral disc is brighter. Then compare it on the stir sequence, and stir is higher in signal intensity. Same patient, super scan. Super scan per se is an exam case where you don't see anything in the kidneys. So this is the super scan, which I just wanted to show you because super scan also comes in the exam, and you should know the differential diagnosis of super scan. Now, this is your last case, then we will take a 5-minute break. Candidate 2.
Yes, I have been
If
presented with.
you let me tell you, because of time factor, I'm going to ask you a leading question.
Okay.
If you see here, this is a T2 weighted sequence, this is a T1 weighted sequence, this is a stir sequence. Now,
Yes.
this lesion here is high in signal intensity on T2 and high on T1 weighted sequence. What comes to your mind?
Fat lesion,
Yeah, so diagnosis, what is it?
lipoma, fat bony lipoma,
So hemangiomas,
hemangioma.
yeah. Now, but I am more interested in the diffuse marrow. Do you
Yes.
think this marrow is healthy marrow? This
No,
is
no,
so.
this is not healthy because the intervertebral disc is more brighter than the vertebral bodies in the T1.
And what is the behavior on the stir sequence?
They showed low signal in the stir sequence. I am thinking about some sort of hemochromatosis or hemosiderosis.
Hemosiderosis. Hemosiderosis. This is a case of myelofibrosis. Myelofibrosis. So myelofibrosis, I'll show you a slide to tell you what is myelofibrosis. And myelofibrosis is, what is myelofibrosis? Myelofibrosis is chronic proliferative disorder resulting in marrow fibrosis. It can ultimately be secondary to other processes like malignancies, but it can also be, other non-malignant etiologies. And so the point is that in this is what we were looking at, T1 very low, and on stir sequence it will remain very low. Now the problem is that the differential diagnosis osteoblastic metastasis. So please remember, if there is a diffuse metastasis of prostate, it can give you this kind of behavior, and then you will end up doing a second study. The second study can be, let's say, a bone scan. It can be a PET scan. And if you give contrast, this thing is, that will enhance, this will not. But nobody does it on a MR. You will have to do a secondary image. And ultimately, they will do a biopsy to rule that out. But the key point here, which I wanted to make, is to develop your eyes on myelofibrosis. This is also in the differential diagnosis of diffused increased bone density. This is in the differential diagnosis of that. Okay, I think I'm just orienting myself. 1 hour, 15 minutes. Okay, so we stop here and we take a 5-minute break. After 5 minutes, it will be candidate 3. Well done, candidate 2.
Thank you.
Candidate 3, are you with us?
Yes, sir.
Okay, so over to you. 15-year-old, how will you describe this lesion?
Um, I'm seeing a lytic lesion, which is predominantly within the medullary cavity in the diaphyseal region of the femur. and it has got um, relatively narrow zone of transition. Although at places it is looking like wide zone also, particularly at the inferior and medial aspect. So my differentials for this lesion would be in this age group. I'll think about a possibility of histiocytosis
And
or
what are the feature? Do you think it's an aggressive lesion or?
yeah, I think because the margins are not very well defined at the inferior and the medial aspect of the lesion. So I
I,
believe that
I
this is
don't
an
know
aggressive.
if it is projecting for you. Do you see something here around the?
Yeah, I can see a bit of scalp. I can see a bit of periosteal reaction as well.
Here you
Yes.
are. So there is a
So
periosteal reaction. Okay, that's fine. So in a young age group, when you find, even if it is aggressive or non-aggressive, LCH or Langerhans cell histiocytosis should be in your differential. So let's go through Langerhans cell histiocytosis and the concepts around it and the types of films which you can expect in your exam. Please remember, usually young age group. Uh, so they can also show you this kind of a, so here, the same case has got a skull candidate 3. The
yes,
same
sir.
has got a nuclear scan. What do you think is happening?
So I can see that there is focal increased uptake on the right side of the
What will you
skull.
do next?
Um,
Let me give you a hint. Classical exam question. What will you do next? When you are looking at a nuclear scan, the examiner will always ask you, what will you do next? Actually, you should have said,
I'll like to have a look at the X-ray initially of this
excellent,
patient.
excellent, well done. So always ask for this because nuclear scans are not reported in isolation. And on X-ray also,
There's a little area.
it is a little area. So now, just concentrate on this. This is beautifully written in Chapman. And which will, there are many concepts in old textbooks which have become redundant. And you should just read it from your Chapman, where there is a beautiful summary here. Uh, you know, uh, Things like Hand-Schuller Christian disease, letter-received disease, they have all been abandoned. Now, basically, Langerhans cell histiocytosis is proliferation of Langerhans cells. Usually it is seen in childhood, but there is a type which can be seen in adults. Now we use this classification: unifocal unisystem disease, 70% of cases. Unifocal unisystem. So and then multifocal unisystem. So in the bones there can be multiple focal lesions. Look at this one: multi-system disease, 10% of the cases, usually less than 2, poor prognosis, permanent. And you should know which, systems will be involved. And look at this: CNS, marrow, spleen, liver, spleen, CNS, skull base, brain, etc., etc., etc. And so I teach it in CNS quite a lot. Like I don't have time to show you CNS today, but in CNS also, that is why it is very important. Coming back to this one, unifocal unisystem. What does it mean? It will be either the bone, as in MSK, or it might be, let's say, the spine, or it might be the CNS, but it will be a unisystem disease. And usually, when it is a single lytic bone lesion, we still call it eosinophilic granuloma, or we can call it a eosinophilic granuloma. Otherwise, the word which is more commonly used now is Langerhans cell histiocytosis. And so the type of findings which you should develop your eyes are very well summarized in this paragraph here, and read each and every line very carefully about it. Everything becomes a 2B film, believe me. Now, in the skull, lesions are usually well defined with a beveled edge. And I'll show you, and this is a classical exam case, beveled edge, where the examiner is going to grill you. You know, there is a lytic lesion, and why is it Langerhans histiocytosis? Vertebra plana is another one. In mandible, lamina dura, I show it in head and neck, not today. And in MR of the brain, for example, there can be enhancement of the dura, etc., which can go into the skull. So I'll now show you key points about this beveled edge appearance. One thing which I want to tell you in CNS, in spine as well as in brain, that the meninges will be involved, so there will be enhancing soft tissue with the bony abnormality. And it can cause what we call vertebra plana. Now, look at this. When it will cause a lytic lesion, and there is a differential diagnosis in your books about lytic lesion. This is given in CNS. And again, that is not my mandate today. I teach it in CNS, where lytic lesion with sclerotic edge and lytic lesion with non-sclerotic edge. So there is a bit of difference between the two. Now the beveled edge, this is known as a bevel. So what is happening? That this is the outer table and the hole there is smaller, and then there is undercutting of the inner table. So that is how it gives you this beveled edge, and uh, it will be seen when it is tangential to the X-ray beam. So if you look here now, where I am pointing out, this is the hole in the outer table, and this one is going into the inner table. So just consider this. And this is what the examiner is going to grill you on, that why is this and why is this that. And please also remember that Langerhans cell histiocytosis, I also told you in lymphoma, can have a sequestrum. And that again is an exam thing. So what will happen? They will show you this kind of a case where there is a beveled edge and there is a sequestrum also. And because of these two things, the grilling will be, you will say it is an osteomyelitis, chronic osteomyelitis, fine. But out of these two, what is most likely? Uh, Most likely, because of these two factors, it is Langerhans cell histiocytosis, and you might get a 8 out of 8 in that film. So this is the fine touch of it. Now, this is a very good example. Look at this lytic lesion. There is a sequestrum here. Do you see this beveled edge here? It is beautifully projected here. Candidate 3, do you see it?
Yes, sir. On the lateral aspect.
Yeah.
Oh, sorry. Yeah.
Even here you can see. So it
Yeah.
all depends on the and 2 + 2 makes 4. So because of this, you will say what else you will consider in. I will consider chronic osteomyelitis. So out of these two, what is your final diagnosis? And you will, because of these factors, it is LCH. This I already showed you. This is another example to show you what we call the sequestrum. Horrible case where you can see so many lesions. And in some of them, for example, where I'm pointing out here, tangential, you can see, and even here, you can see this beveled edge. So many multiple lesions. Vertebra plana, the differential diagnosis. This differential diagnosis, take a screenshot of this. Vertebra plana is a differential diagnosis which per se you should remember in a child. So without history of trauma, I mean to say. So this is the differential, and LCH will be up there. And please remember that these patients, these vertebra, they heal actually, and they become normal. So this is similar case to what we should did see the first case which the candidate 3 did. And even here, there is a lytic lesion with periosteal reaction. So this is in this age group, because of the age group, LCH will be there. Now, this is the key take home for you. Key take home. It is possible anywhere. Remember this. If it is a child, if it is a PEDS group or a young patient, it can be anywhere. So a lytic lesion in the phalanges, keep it in the differential. In the metaphyses, in the epiphyses, in the diaphyses, everywhere. So that's a key point for you to remember. Okay, now what kind of femur is this? Describe this. What word will you use for this femur? Shape of femur.
The shape of the femur looks like Erlenmeyer-Class deformity.
Excellent. Now, this case I'm just showing you for the sake of differential. The same femur has got this, and this is quite a historic film. These days they don't do it, but uh, this is a case of Gaucher's disease. So nobody is going to diagnose a Gaucher's on this film, but I just wanted to show you because this is a depositional disorder, and this can also cause this shape of the femur. And in the past, they used to do these procedures. We used to call them decompression. The idea was to pass intramedullary nails in the head of femur, and the concept was that this will prevent avascular necrosis. So this becomes a story, sort of a story in that era. But I just wanted to show you because of this thing, which this differential you have already done. Yes, please. 28 years old.
Um, So this is X-ray of the knee, AP and lateral views, and I can see uh, that there is irregularity of the bony outlines, along with patchy areas of sclerosis as well, and the joint also, the intercondylar notch also looks a bit widened to me. And on the lateral view, I can see that there is some increase in soft tissue density as well at the anterior as well as the posterior aspect of the knee. Um, the joint also looks a bit disorganized. Um, mm, Considering the widened intercondylar notch and a male patient, I'll be thinking about possibility of hemophilia in this case.
So what's happening to this metaphysis? Sorry, epiphysis.
This looks a bit broadened
Why is it broke?
because of the uh, because of the bleeding tendency and secondary hyperemias.
So what happens in secondary hyperemia?
Because of increased blood supply, the bone tends to overgrow a bit, so it tends to
Excellent,
appear a bit
excellent.
larger.
Well done, well done. Let me take over. Now, you know, in hemophilia, what happens is that uh, key thing which you have to remember is think like this, that the radiology or the radiological features which we get, the exam features which we get are because of bleeding. This bleeding can be within the within the joint cavity, number one. Number two, it can be within the bone, and it can be in subperiosteal or in the adjacent soft tissue. And this makes different kinds of radiology. So this is the key point: intra-articular, intraosseous, or subperiosteal slash soft tissue. Now, key points to remember is that the most important or most commonly involved is the knee joint, then the elbow. So these two are most important. And but I particularly want to highlight calcaneum. And I also want to highlight small bones of the hands where you can get, what we call pseudo tumors. And because of abnormal or slightly unusual locations, these are favorite in the exam. Basically, uh, if there is cavity, joint cavity bleeding, repeated bleeding, basically what is happening that there will be, because of hyperemia, as the candidate pointed out very well, there will be inflammatory synovitis. And then there will be cartilaginous destruction, one. Number two, erosion. So secondary OA type changes, subchondral cyst. Then there can be overgrowth or ballooning of the epiphysis and metaphysis due to hyperemia, and diaphyses are gracile. If if there is large effusion, repeated effusion because of hemosiderin, there can be increased density. So this makes the radiology. On the other hand, when there is intraosseous bleeds, it will produce an expanded lytic lesion, and there will be endosteal scalloping. So where is this lesion? It is in the medullary cavity. There can be endosteal scalloping and cortical thinning. If it is in subperiosteal soft tissue, it will cause extrinsic bony scalloping, or should we use the word, periosteal bony scalloping? And it will give you a bizarre type of appearance. Once you remember it like this, you will master this. It's a very important exam case, by the way. And the key differential is JIA, juvenile idiopathic arthritis. So let's go back to the case which the candidate described very well. If you see here, look at the epiphysis, overgrowth. It is larger as compared to this one. Intercondylar notch is widened. And then look at the articular surface, it is irregular and there are cortical erosions, etc. Now, once you pick it up, a bit of stretch of imagination, but one can argue that this is the patella and look at the effusion, it is quite high density. So this is the type of what is, written in the books, that the effusion will be high density. I've seen a few cases in my life. I've never seen this. This is from ACR's teaching files, but it is given in the book. But here one can convince ourselves that this is it. On an MR, of course, on a gradient echo sequence, it will be low intensity. The classical differential is JIA. This is a JIA. And if you ask me, there is not much difference. Of course, the high density of soft tissue is not visible, but I also told you that it might not be visible in each and every case. Look at this intercondylar notch widening. Look at this epiphysis overgrowth. Look at the cartilaginous destruction, and so quite similar. The pathophysiology is hyperemia. In JIA, this is because of inflammation. In hemophilia, it is because of recurrent bleeds in the articular cavity. So, uh, look at three differentials from your books: asymmetrical maturation, chronic hyperemia, and it includes juvenile idiopathic arthritis and hemophilia. And then look at this one: premature closure of growth plate. Premature closure of a growth plate can occur because of localized hyperemia, like JIA and hemophilia. And enlargement of the distal femoral intercondylar notch, again because of hemophilia and JIA. They go together. This is another case of JIA. And look carefully, look at this epiphysis. You will agree that this is larger as compared to this one. Similarly, the findings are bilateral, but they are slightly asymmetrical. They are more pronounced on the right side. Look at the destruction, etc., in the joint cavity, more pronounced on the right side. Another case from STAT-DX, where you can see intercondylar notch widening, and you can see this secondary destructive change. You can see the epiphysis enlarged, And yes, candidate 3, describe this.
So I've been provided with 23 years old male, elbow X-ray AP and lateral views, and here I can see that the mm, that the bones are looking a bit um, overgrown again,
Which bone is
particularly
overgrown?
the radial head is looking a little,
Excellent.
uh,
And
and,
what other
and
than that,
sorry,
other than that, any other finding?
the ulnar articulation also,
So how do you
the
describe this lesion here?
yeah, that's a lytic area
Hmm.
in the olecranon process.
Right. So
Of
what is your
the
conclusion? What is your conclusion?
So that can be a hemophilic pseudotumor um, in this patient.
Okay. Now I'll come back to the case. Uh, you're right, but I'll give you the findings once again. Now there's a differential in your book, lucent epiphyseal bone lesions. Lucent epiphyseal bone lesions. This list is extremely important in the end. Bone lesions which can occur anywhere. And so metastasis, brown tumors of hyperpara, lymphoma, myeloma, hemophilic pseudotumor. It can occur anywhere. And I think we should add LCH also there. Now, because it's not, it is adult, so they have not mentioned it, but in a child you should. Now, uh, if you see here, this is the same concept, intraosseous bleed. Intraosseous bleed. It can cause pseudotumor. So coming back, so what happens is, in this case, this is the joint, and you were absolutely right that this is expanded because it is within the joint space, and there is a lytic lesion here. One can explain it on intraosseous. One can argue that there might be OA, but this thing is much bigger than just a GO. Now, uh, few other examples. This is another one in which a bit of expansion is there, and on a MR, on a gradient echo sequence, there is low signal in keeping with lead. So if they show you an MR, and this is also true for another entity in joints, which is PVNS, pigmented villonodular synovitis. Uh, I think the terminology is now changed, but most of the people still use this. You should ask for a gradient echo sequence to take up hemosiderin, which will cause blooming artifact. And so that is the MR world. Another example where you can see, look at this polychronon process, and it has got an expansile lytic lesion, and the head of radius is slightly enlarged. There is secondary OA, and this lucency actually is projecting here also. And this is again because of intraosseous, pseudo tumor. How do you describe this case? Over to you, candidate 3.
Here in this patient, I can see that the right hip joint is disorganized and the hip is dislocated, and there is possible a pseudo articulation seen of the right femoral head with the iliac bone just above the right acetabulum. I can see because I can see some concavity there, which seems to be because of early pseudo articulation getting formed. In this case, besides this, I can also see some sclerotic area which is adjoining this suspicious area of pseudo articulation along the iliac aspect. Besides this, okay. Mm, I think there is a large lytic area in the right iliac bone. So I think that is possibly because of a hemophilic pseudotumor, or there can be other DDs as well. But yes, that's the lesion, large lesion, which I was seeing in the right iliac blade. Yeah, right iliac bone. Sorry.
on the CT. Yeah?
Yeah.
So this is, these pseudotumors, particularly when they bleed into the periosteum or adjacent soft tissue, they can cause a lot of destruction. And they will give you a bizarre is the word, and it was given in that stat dx slide which I was showing you. Bizarre. It will be absolute destruction. You will, what is happening? It is, and it has completely destroyed it. It has caused dislocation of the hip joint, and there is a hematoma here. So this was the pseudotumor part of it. Another example here, you can see. To show you various examples is also to develop your eyes. And once you see it, you will never forget it. If you have not seen it, your mind will never go to, is it a hemophilia? No, it can present like this. And look at this one.
Uh, so in this
So
child,
let me take over. There
okay,
is
sir.
a expansile lytic lesion with internal trabeculation in the femur, correction, in the calcaneum in a 14-year-old. What is your differential?
It can be it, uh, it can be because there are septations and there are loculations get seen within this lytic lesion, so it can be an ABC also. Besides,
Very good thought. Very good thought. Anything else?
it can be cartilaginous tumor as well.
Which one?
I think I can't remember right now very well. Maybe chondroblastoma or
What is the location of a chondroblastoma?
epiphysis usually of the long bones.
Mhm.
But there are some tumors which can happen in the talus and calcaneum as well. Some cartilaginous tumors, which I don't remember well. So, so in the
Just one
epiphysis,
second. Just one second. Look at this. Lucent epiphyseal bone lesion.
yes, sir.
This include carpal and tarsal bones since they are epiphyseal
Epiphyseal
equivalent.
ligament. Okay, so we can think
So
about
I always tell you that in Chapman, one line can save a case for you. And this is the concept, which is tarsal bones, all of them are considered epiphyseal equivalent. So you are in a way fine, but where are we? We are here. So
So
anything
I'll
else?
definitely like to keep chondroblastoma as well in this in the differential.
Chondroblastoma will cause this expansile type of an appearance. You cannot, now, this is the fine touch of differential diagnosis. You have to tell me not on just your theoretical knowledge that it is because of epiphysis, you also have to correlate with the radiological features. So
Okay.
chondroblastoma will appear like this, expansile.
No.
Okay, good. So that's the correct answer. So then what? You said ABC. What else?
Um,
So the differential is in front of your eyes.
Expansile. Then I think it can be from the miscellaneous category. I think it can be again a pseudotumor of the
So
calcaneum.
I'm expecting you to consider these things and then rule it out or rule them in
Okay.
location-specific lesions. Intraosseous lipoma, calcaneum central calcification. So you have to
So
tell
there
me.
was.
Yeah, so again, the importance of Chapman. You see, this is a specific case in which I am grilling you. The examiner is grilling you on a lytic lesion of the calcaneum. And this tells you the fine touch in the exam, how you can get more and more marks. You might pass just by calling it one odd differential, but if I'm an examiner, how will I give you 6 versus 7 or 7.5 or 8? This is how I will give you that I can consider intraosseous lipoma. However, it will not cause this expansile trabeculated appearance, and usually there will be calcification. I can consider a simple bone cyst. However, this is not a simple bone cyst, it's more expansile with a trabecular pattern,
Yeah.
right? So, uh, it is not a chondrosarcoma, so we are in this world then.
Yeah.
Uh, and because of this expansion, and the way it is expanded and things like that, I think we should keep it up there, isn't it? Hemophilia
Yes.
severely. So this is what you have to, for your exam, you have to, the skill which you have to master. And so this is pseudotumor of the calcaneus. Yes, please, another one for you. Are you with me?
I'm there.
Yes, please. Over to you.
Hello.
Yes, I can hear you. Please continue.
Hello.
I can hear you. Please continue. You can hear me? Candidate 3, we can hear you. Oh. Candidate 3 is...
I just unmuted. Yeah.
Yes. So
Hello.
now, please continue. I can hear you.
Okay, so I've been provided with the X-ray of the possibly left thigh region of this 19 years old male patient, and again I can see that there is some increased soft tissue density in the left upper mid thigh region, and which is leading to some scalloping of the underlying femoral bone on both the sides. And besides that, the femoral bone is also showing areas of sclerosis. um, uh, so possibly it can be due to some soft tissue pathology. It can be because of um, can be
Good
because
thought.
of
Good thought. So what is happening, if you stretch your imagination, what is happening is that there is what we call periosteal scalloping here, periosteal scalloping here. So something is sitting there and it is causing this scalloping. Something is sitting there causing this scalloping. It is bizarre, isn't it? Absolute
yeah,
bizarre, right? So
yeah,
the eye
yes sir.
see what the mind knows. Nothing can explain this. This was
Yeah.
another case of hemophilia, and this is what I was telling you that. Do you see this? This is if subperiosteal or soft tissue neural extrinsic bony scalloping with sharp margin, bizarre periosteal reaction. Important. So now you have seen another presentation. And this is what this exam is about. If an examiner has got this unusual presentation of a common condition, it's not a common condition, we know that, but this one is, if you have not seen it, you will never pick it up. If you have seen it, you know maybe 8 out of 8, right?
Yes sir.
Okay, good, well done. Yes,
um,
please.
So I've been provided with the DP view of both hand, including the wrist region, and of a pediatric age group child. And here I can see that there is cupping, along with cupping from fraying as well as splaying at the distal ends of the radius and ulna on both the sides. So I believe that this is a case of rickets, and besides that, I don't see any other obvious abnormality in any of the other bones.
Can this
Of
be scurvy?
Sorry, sir.
Can this be scurvy?
No, I don't think, because like I don't see any such change, a change in the epiphysis of on both the sides. There's no evidence of Wimberger sign, or besides that, although I can see a dense band, which is Frankel zone, which is seen in scurvy patients. But since the epiphysis looks quite normal to me on both the sides, and there are no obvious Pelkin spurs, so and the predominant finding, I believe, is the cupping, fraying, and splaying. So I believe that this goes more in favor of rickets rather than scurvy.
Do you think this cannot be a Pelkan spur where I am pointing out, or this one here?
Mm, maybe it's just pseudo appearing because of the cupping of the distal and the radius and ulna.
Okay, well
So
done, well done, very good. I'll take over. Now,
okay.
in rickets, what happens is now we are into the world of metabolic. Uh, so please remember the concept that bone is made up of two components. One is protein and second is mineral. I am keeping it very, very simple. The protein is known as osteoid, and the mineral, of course, the calcium is the main thing. Now, uh, if calcium is deficient, then we get rickets and osteomalacia. On the other hand, if osteoid is deficient, then scurvy is an example of osteoporosis. So we call it osteoporosis, and there can be various other etiological features for osteoporosis, hormonal and blah, blah. But scurvy is osteoporosis, osteoid is deficient. In rickets, calcium is deficient. Now, when there is a growing skeleton, there is a what we call a zone of growth plate, and there is a zone of provisional calcification. So from here to here or from here to here is the growth plate. So because the growth plate, so usually the growth plate is calcified. We call it zone of provisional calcification. Because there is no calcium, then what will happen? As the candidate very well pointed out, there will be uh, there will be look at these words. There will be widening of the growth plate. There will be widening of the growth plate. Then there, look at these words: spraying, splaying, and cupping of the metaphysis, which is also of reduced density. Now, tiny bony spurs extend from the metaphysis to surround the uncalcified, this C here. And this is what I asked the candidate, and he tackled it very well. Basically, uncalcified cartilage is here and it goes around it because a Pelkan spur of scurvy sometimes is confused by this appearance. So the idea was not to be get confused about that. Now, other than that, another main finding which I want you to remember is increased non-calcified osteoid in the immature skeleton mainly is a disorder of growth plates and equivalents. Growth plates and equivalent. So in the rib, what is the equivalent? Costochondral junction. And that is why in the ribs, that is an exam film, you will get expansion of the costochondral junction. And coming back to this, and this is again from Richard Penn, there are changes due to bone softening, which and basilar invagination, particularly, you is an exam case which you should know. I think I do show you films about it, but that is in the congenital one. So this is a bit of theory. Another example here where there is cupping. And now candidate three, what is your finding
Yes,
here?
sir. Um, so uh, in this child, I think there is some widening of the anterior aspect of the ribs, uh, or grossly. Otherwise, the bones and the lungs look normal to me. The cardiac outline is also looking normal to me. Uh, yeah, I think on the lateral view also, I think the anterior aspect of the ribs are looking a bit bulky. So that can be because of the rosaries that we, rachitic rosary.
Yeah, okay. So please remember this film per se can come as the first film in your exam. The examiner is going to show you a lateral. And when you get a lateral in the exam, your adrenaline goes up because this generation, your generation, young generation, you don't see laterals. So you start looking, why have the examiner? So actually, this is the costochondral junction, and you can see the same cupping here. And you can see this expansion of the costochondral junction. And the key thing was this line here, which is equivalent costochondral junction equivalent. So this is classical. Over to you.
Uh, this 5 months old child X-ray. Um, 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 um,
Look at the ribs. This is your last case.
okay. Um, I'm not able to make out maybe.
What do you think
So,
about this?
okay, so again, the anterior aspect of the ribs are looking bulky. So again, could be rachitic rosary again.
Look at the left-sided ribs.
The left sided ribs are probably fractured at the lateral aspect. Uh,
So,
Sorry, sir.
so conclusion.
So, since the child is 5 months of age, I don't think it can be a case of rickets because normally we don't see rickets in in early infancy. Uh,
What are you thinking?
I'm not able to make out, but I don't think it's a case of rickets because the child is less than 6 months. Okay.
So the point is this was a you see the A to Z course when is very easy because you know where you are. You are into the metabolic world, but this was a trick case, and this is what will happen in the exam. That please remember in NAI, classically you see metaphyseal fractures, and just like rickets, the fractures can be at the costochondral junction, which can manifest as expansion. On the other hand, in this case, as you correctly pointed out, that on the right side there is expansion, but immediately you picked up that there are fractures here. Please remember, when you do a skeletal survey for a suspected NAI case, you do obliques also. You Obliques is a better view to pick up fractures, and these fractures are confirmed there. And so immediately, once you have confirmed it, means it is an AI. Now, one thing which I want to tell you is now we have changed the word for NAI once again. In my radiological lifetime, I think we have changed it so many times. The first David Sutton, which I have, 1987 edition, the word battered baby syndrome is there for this. And then we said it's politically incorrect to call it this, another word, NAI. Now we have changed it to suspected physical abuse. So in UK, now the latest is that if you want to impress the examiners, use this word suspected physical abuse. I am sure they will not mind if you still use the word non-accidental injury. So this is a case of NAI. Why I wanted to show you here that the same radiological finding can be seen in NAI as well as in rickets. Thank you very much, candidate 3. Candidate 4, are you with us? Candidate 4 is unmuted now. Candidate 3?
Yes,
Yes, I
sir.
can hear.
Thank you.
Yes, I can hear you.
Yeah, candidate 4, are you with us?
Yes.
Okay, so sometimes healing rickets can show this is the manifestation of healing rickets where metaphyseal band can be seen. And this is, I just wanted to show you that the differential diagnosis of solitary radiolucent metaphyseal band, we did cover leukemia, lymphoma, and metastatic neuroblastoma. Healing rickets, which is this one, is a healing rickets case. Uh, and so then finally it is healed completely in a follow-up X-ray. Yes, please.
I am presenting with
Look at
both.
the tibia. Look at the tibia.
Yes. There's a point of the left tibia. I think point of both tibia more on the left side.
Mhm.
There's also I think there's the impression of spare medially, Belkin spare. And there's also
Right. So if you see here along the shaft of the tibia and this
yes,
shaft here, what do you see this?
yes, there's a bilateral periosteal reaction.
Mhm. How do you explain that?
Diagnosis or
Yeah, okay. Diagnosis.
yes, this is a case of congenital syphilis.
Congenital syphilis. So
Yes,
what is the appearance here of the metaphysis? Sorry, the distal epiphysis and the metaphysis.
there's a professional zone of calcifications. Yes.
So do you think this is rickets?
I don't think this is
Right. Okay, let me take over. Now, this differential diagnosis is my favorite differential diagnosis. I think I've taught this many times, which is periosteal reaction bilateral symmetrical in children. And I don't have time today to teach everything, but we'll just concentrate on the film itself, rickets. Basically, if you go back to the pathophysiology, what happens is that in a usual growing skeleton, what is happening, we know that there is osteoblastic and osteoclastic activity. So under the periosteum, new bone formation is happening. This is normal physiological. And in rickets, sometimes what happens is that there is deposition of this osteoid, which is devoid of any mineral, any calcium. So it gives you an appearance of a periosteal reaction, a mimic. In the presence of uncalcified periosteal osteoid mimics periosteal reaction because the periosteum and osteoid cortex are separated. Now, if you see here, this is it. actually, in this particular case, you can see that there is a bit of cupping here. You can see a bit of bowing here of the bone. Now, if you go back to this, the features of rickets from the bone, from your book, Chapman, changes at the growth plate and cortex, changes due to bone softening. And these are the ones which we were concentrating. And look at this, changes due to bone softening, bowing of the bone. Now, even here, it is written indistinct cortex because of uncalcified subosteal osteoid mimics a periosteal reaction. So this is why I take emphasis on this, that each and every line can save a case for you in the exam. And so it's a unifying diagnosis. There is a bit of metaphyseal cupping and then bowing of bone, and within this periosteal reaction. By the way, in congenital syphilis, you will find metaphyseal erosions here. So you don't see that. And you will not see this finding in congenital syphilis. Okay, candidate 4, over to you. This is, let me give you the scenario. This is the type of film which comes usually as a icebreaker in the exam. Maybe the first case, we call it a warm-up case. Just look at the bones. Anything abnormal in the bones? Can you, yeah, please continue.
Yes. There's a
Okay, in the chat, anything. This is for the chat. Anything abnormal? Everybody can participate. So, okay, somebody has picked it up. If you see here, you can see this lucency here, and you can see a similar lucency here. This is loser zone. Candidate 3, when do you see loser zones? Sorry, candidate 4.
Yes.
When do you see what is the pathology when you see loser zones? Which pathology?
Osteomalacia.
Yeah, osteomalacia. So the concept is that in osteomalacia is the adult version of rickets. Here, what is happening is that in usual bone, repair and metabolism, what happens is that the concept is that there are micro infarcts, it just goes on, they just heal. But in this case, when they heal because of osteoid, which is lacking calcium. And usually it is perpendicular or oblique to the cortex. Key point to remember is that you have to know the sites. And please remember the key concept that it has got nothing to do with bone, weight-bearing bones. So the common sites include ribs. So they will show you a case in the exam in which osteomalacia loser zone will be on a chest X-ray. And once you pick it up, then they will simply take down the film. Number 1. Number 2, scapula. Then, in the pelvis, the pubic rami. Then upper femora, the medial upper metaphyses and diaphyses. Even they can occur in fibula and things like that. So scapula is a known site, and this is a loser zone, and this is a loser zone. Once you pick it up, the film will go, and you will go to the next case. This is another example, another case. This is not the same case. Do you see any loser zones? Candidate 4.
Yes, on medial side of both femoral neck.
Excellent. So here you are. You can see it here, and you can see it here. Just remember again and again that today you know what you are looking for. In the exam, you will not. So, these areas should be, in a way, these findings should be in your review area. Now, this is a good example where in the fibula, you can see it. And fibula is not at all a weight-bearing bone. So, another case of osteomalacia. Now, this is a classical exam case. Do you see a loser zone here? Over to you. Okay, open for chat. Anybody has picked up a leisure zone? Where is it? Yes. Okay, good. So if you see here, look at this one. And by the way, I'll show you a close up, but this is it. This is it. But having said that, retrospectively speaking, actually, it can definitely be seen on this X-ray also. So this is a loser zone in the ribs. Yes, please describe this X-ray for me and give me your diagnosis.
Presented with a 3-year-old male, knee X-ray, AV and lateral. There's a thinning of the lower femoral epiphysis, giving the Womberger signs. There's also a thickening of the distal femoral metaphysis, giving a tremor field zone adjacent with the loosening radiolucent area, giving the Franklin zone. These changes can also be seen in the tibia and fibula on both sides and on right and left also can be seen. No subperiosteal hemorrhage, no fractures. These findings are suggestive of scurvy.
Okay. Now let's repeat the findings and then we'll come back to the film. Please remember scurvy, as I told you in the beginning, that it is by definition an osteoporosis. So the osteoid is lacking, and it cannot happen before 6 months of age, and that's a viva scenario. Don't consider it in the differential. If you find a, let's say a periosteal reaction, things like that. Now, basically what happens is that osteoporosis, which is usually seen in adults, Wimberger sign, reduced epiphyseal density with a pencil-thin cortex. So this is the epiphysis. This is reduced density, and the cortex is sclerotic and it is pencil-thin. You can see it here. You can see it here. Now this was one. Then Frankel line, zone of provisional calcification in the metaphysis. So this calcification is normal, but it gives you this slightly fluffy type of appearance because calcium is normal, right? And then Trummerfield zone is lucency under the Frankel line, not very well projected in our example, but you can imagine that somewhere here is a lucency under the Frankel line. And this is what I was talking about and differentiating with this appearance in scurvy, where this is because of splaying around the non-calcified cartilage. Here, the concept is Pelkan spur. Pelkan spur, the concept is that because this is micro fractures, and this is secondary to bone weakening. And it also results in metaphyseal cupping. So in a way, there is cupping, but the mechanism is different, and that's why this should be discriminated with this. Both conditions can cause metaphyseal cupping. Key exam point is this one, periosteal reaction due to subperiosteal hemorrhage. You remember in hemophilia, what happens when somebody bleeds under the periosteum, it causes those, so much reaction and things like that. Similarly, in scurvy, it can happen. Not in every case, but it can happen, and that becomes a exam case. So in this case, of course, we have already covered it. Wimberger sign, Pelkin spur, and Frecklin line, etc., etc. Now, yes, please. This is 4th of September. This is and this is 18th of September. What is happening?
Yes, there's a extensive subarachnoid hemorrhage involving both humerus, involving both femur.
So conclusion?
Scurvy also.
Right. So if you see, some of these signs are visible here on the previous X-ray where Wimbergen sign, etc., is seen. Then what happens is when there is subperiosteal bleeding, it will cause periosteal reaction like this. And that is why it comes in the differential diagnosis of this bilateral symmetrical periosteal reaction in a child. And so this is the manifestation, which is very important. What do you think is happening here? Candidate 4. Look at the metaphyseal NAI. Okay, good. So here what is happening is that if you see, there are metaphyseal corner fractures, bilateral, and there is periosteal reaction. It's a classical location, and this is also suspected physical abuse, or previously known as NAI. What do you think about the bone density, first of all, in this case? Because do you think it is increased or not increased?
I think it increased.
Right. So you are right because it is not projecting very well. So I just wanted to confirm that it is increased. So it's a 14-month-old female. The bone density is increased. Any other finding?
There's also widening of the lower distal femoral metaphysis, giving Erlenmeyer-Fast deformity.
I don't think so. That's a very convincing finding.
Okay, there's a periosteal reactions.
Right. Where and where?
Along the ulna and femur, right femur.
Excellent. So we have got a case in which there is generalized increased bone density, number one. And number two, there is periosteal reaction at two different locations along the diaphysis. What do you think can be the cause? And look at the age, it is 14 months old.
Yes. Could be either due to prostaglandins or lead poisonings.
No, prostaglandin and this is vitamin A toxicity. Vitamin A toxicity. And so vitamin A should be added in this list, periosteal reaction, bilateral symmetrical. And please remember in your book, in the pediatric part, it is given there, generalized increased bone density 14.8. And it is chronic hypervitaminosis A. So you don't see it less than 1 year of age. Remember this. Cortical thickening of long and tubular bone, especially in the feet. So that is very common in the feet. Subperiosteal new bone formation, normal reduced metaphyseal. The mandible is not affected, but it is generalized increased bone density. Now, these things are very important. Why? Sometimes in the exam, a simple case comes. For example, generalized increased bone density. And the examiner is going to grill you on this. What else? What else? What else? So the finding is extremely easy, but the grilling becomes difficult because they are trying to look at your thinking process, and you have to rule out this and rule out that. And that is why now from today onwards, keep this in your differential. One thing which I want to highlight is that look at these four poisonings. There are four poisonings: lead poisoning, fluorosis, hypervitaminosis D, and chronic hypervitaminosis A. We have not covered them and they are in the mandate for today, but I'll tell you the plan. Remember all of these in the pediatric age group. And key point to remember that out of these, only fluorosis occurs in the adult age group. So it will be generalized increased bone density. It can cause in more common in adults. You see, it is written here, more common in adults. But these four are in the children. Now, vitamin A toxicity, what happens is it's a fat soluble. Uh, uh, so we can eat it, and usually the dose, and so periosteal reaction, regular or wavy, dense along long bones. There is another finding which is a very unique finding, and I am going to show you an example because if somebody shows you in the exam, it's a very unique finding, and you should know coned epiphysis with possible early fusion across physis. Look at this epiphysis here. You see this thing? And look at the shape. This is as if it's a volcano or something, and so this is known as coned epiphysis, coning of epiphysis, very unique, which can happen in hypervitaminosis A. And there is increased bone density, increased bone density, increased bone density of this various examples. I think what I will just show you 2 or 3 more cases. In 5 minutes, we will stop. I've changed my strategy because what I realized is that there is still too much to cover and I did not want to rush. So what we will do is that after, I think next 2 sessions, uh, uh, next session, we are doing a mock viva, and Dr. Akash, who did a viva very recently, he will do it, and it will be a mock viva, classical mock viva. And I think the 3rd of October session is also booked for somebody else. But what I will do is after the 3rd of October session, I will cover all of this, whatever is left. We will start from wherever we stop because there is too much to cover. And then I realized that soft tissue, there is a chapter on soft tissue, which also needs to be covered. So let's do it in a second session. So now I will just show you maybe the last case and then we will stop. Last pathology, should I say. Yes, please, candidate 4. What is this?
Sacral insufficiency,
Say
fracture,
again.
H shape.
Yeah. So what is your diagnosis?
Yes. Osteoporosis,
Yeah.
fractures.
So this is a stir sequence, and a stir sequence where bone marrow edema can be seen in the sacrum. And look at the shape. It is H shape. We call it Honda sign. And this Honda sign, of course, again, this is an exam case on a nuclear scan. It can come on a nuclear scan. So this is Honda sign. And the final thing which I want to cover today is Cushing's syndrome or Cushing's disease. In Cushing's syndrome, the key exam thing which you have to remember is that there will be fractures, for example, in the spine, in the ribs, and they can be spontaneous fractures. Key thing to remember is the callus formation, which is exuberant. And this is quite a unique phenomena in Cushing's. So you will see these fractures and you will see, this sclerosis is slightly more than what is expected. And this is because of exuberant callus formation. Please also remember the concept behind Cushing's syndrome versus Cushing's disease. And from here, long cases can be asked. So this is, remember that Cushing's disease is when there is adrenal disease, adrenal adenoma, because cortisol is, production is high. On the other hand, the same thing can be because of lung cancers, or it can be iatrogenic. And do not forget, sorry, I was wrong there. Cushing's disease is because of microadenoma. This is syndrome. So the microadenoma of the pituitary that can cause Cushing's disease. So Cushing's disease and everything else is syndrome. This one is disease. So now what the examiner can ask you, if you have got this concept, then they can show you mix and match type of films, or they can show it to you in a long case. Some microadenoma sitting in the pituitary and something like this, with no history of trauma. Look at this case from literature. Multiple spontaneous rib fractures in a patient with Cushing syndrome. So here you can see spontaneous, but in a long case, suppose this chest X-ray is there and a pituitary microadenoma on an MR is there, and you will be worried, how can I correlate the two? You will pick up both findings, and the scenario given will be such that there is no history of trauma. So this is the type of things which two different, once you know the overall concept of an pathology, then you can understand the mindset of the examiners, how they can show it to you. So this is a very good example of spontaneous fractures. So what we will do is, okay, there is another case, candidate 4. This is your last case of the day. This is a 36-year-old and the patient has got bilateral heel pain. Over to you.
This is an X-ray of bilateral foot, lateral view. There is a sclerotic lines involving the calcaneum, more on the right side.
And conclusion?
Calcaneal stress fracture.
Excellent. So please remember, and this is the type of case which can come in the rapid reporting also. This is known as insufficiency fracture of calcaneum due to osteoporosis. So the osteoporosis per se is not visible on radiograph, but the stress fracture is. Insufficiency, the insufficiency fracture. I used the wrong word, stress fracture. Please remember, insufficiency fracture versus stress fracture. You should have clear-cut idea of the definition. Insufficiency fracture is normal pressure on normal stress on abnormal bone, and the stress fracture is abnormal stresses on normal bone. So an athlete who is running too much and causes this stress fracture. So this is insufficiency fracture, and this insufficiency fracture I wanted to show you because it is a rapid reporting film also. So when there is sclerosis here, particularly perpendicularly oriented sclerosis, this is considered quite pathognomic, particularly in the context of heel pain of a insufficiency fracture. Right. So what we will do is that we will stop here. Well done, candidate 4. We will stop here, and as we have decided, I think it is not on the website till now, but next week there is going to be a mock exam viva. Dr. Akash is going to do. We will put it on the website. And number one. Number two, on 3rd of October, I think there is a session by somebody else. Yes, a MSK session is there. And the week after, I will continue with this and finish this because there is too much to cover. So, okay, thank you very much. The chat is open if there are anything for the next session or anything else you want to ask or you want me to cover when I do that session, let me know in the chat. And if the co-host can put the link in the chat, the feedback link, I mean to say. Thank you. So the link is now with you.